Yes. Good evening, all. Should I start, Palli ma'am?
Yes.
Please
Yeah.
start, sir. Please start.
Yeah. Good evening, all. On behalf of MyIP, I, Dr. Kundan Chopde, welcome you all to yet another episode of Protocol in Pediatric Practice. This is the monthly webinar, online webinar that will be useful to elevate your practice. That is, this webinar will bring together the experts in pediatric medicine to guide us through essential protocols, ensuring a comprehensive understanding of handling the cases. This is the fourth webinar in this series. The first was Approach to Comatose Child by Dr. Sachin Jangam. Second was Diabetic Ketoacidosis by Dr. Mohin Tamboli. And third was Neonatal Jaundice by Amit Tagare. Today we are going to focus on dengue fever. This topic was suggested by our President Sir Dr. Ram Gopal Sir, as the monsoon is approaching and there will be increased cases of dengue. So this will prepare us all us together to manage the cases efficiently, and that will be helpful for our patients also. The most important is today's speaker is Dr. Dhanya Dharmapalan ma'am. When we approached the madam was busy. She was in a conference, pediatric infectious diseases, and yesterday also she was having a talk at international platform. Still, she has agreed and prepared for this talk. Thank you, ma'am. Before we begin the session, I will request President sir is there, Ram Gopal sir.
No, sir is not there. Sir is not traveling actually.
Yeah. Then I will request our dynamic, ever smiling Secretary General Dr. Amol Pawar to speak a few words.
I'm really sorry.
Thank you.
Yeah. Please, sir. Please tell, sir.
Thank you, Dr. Kundan. As you rightly told, Dr. Dhanya Dharmapalan is not only national, she is the international faculty, and she was my 1 year senior at Pravara Medical College. And since last 3 months, we are catching her, but this time we got her on MyIP platform. And I welcome all the delegates, all the PG students, all the experts, then all the senior IIP members, Maharashtra IIP executive body members, and also MMC observer Dr. Sanjay Gosavi sir, senior pediatrician from Nasik. It is our privilege that another dynamic Navi Mumbai IIP and Dr. Jitendra Gawane sir had joined right now in this session. So I welcome once again to all, and this protocol in pediatrics, this is very nice concept, conceptualized by Dr. Bhavesh Mithia sir, and it is running well. So now I request Dr. Jitendra Gawane sir to have some words with us on this occasion. Jitu sir, please.
Yeah. So good evening, friends. Indeed, Ram Gopal and Amol are selecting the topics at appropriate time so that we all are well versed with the current things going on around us or anticipated around us. So today's topic is well chosen, and speaker also. We at Navi Mumbai's pride, Dr. Dhanya will teach all of us about dengue fever. We all learned from her and Evle sir, and let us all learn pearls of wisdom, the fluid management from her. And without wasting time, I hand over to my friend Dr. Kundan. Thank you.
Yeah, thank you, sir. Thank you. I also welcome Dr. Bhavesh Mithia sir, scientific convener MahaIP, all central EBs, all EB and OBs of Maharashtra IIP for gracing this webinar. I also welcome MMC observer Dr. Sanjay Gosavi sir, senior pediatrician from Nashik. There is one announcement that Solapur Academy of Pediatric is hosting MahaPedicon 2024, where I am organizing secretary along with Dr. Samir Khan and Dr. Keur Shirsi. Organizing chairperson is Dr. DP Nakate, and we welcome you all to Solapur for this MahaPedicon. Dr. Dhanya madam is also going to be there as a faculty. Pallavi ma'am, can you put the video of organizing chairperson, sir? Amol sir.
Kundan?
Yeah, I have told madam to play the video.
Can you share from your end?
No, I'm sharing. Just a minute, sir.
Okay,
Just a
yes.
minute.
Good evening, friends. Myself, Dr. D.P. Nakate, organizing chairperson of Maharashtra State Pediatric Critical Care Conference 2024, which is to be held in Solapur on 13th and 14th of July 2024 at Balai Solapur. And the workshops for this conference are to be held on 12th July 2024 at different hospitals of the Solapur city. So, on behalf of Solapur Academy of Pediatrics and Maharashtra State Academy, I request each and every pediatrician of Maharashtra State to get participation in this conference, as it is not the conference of pediatric critical care, but it's all the pediatricians are those who are practicing as OPD practitioners as well as at primary and secondary critical care work. And as we know, each and every pediatrician is one or the other time facing emergency patients. So it will be a very good and useful conference for each day-to-day practice also. So I request every pediatrician to participate in this conference. And along with this conference, you will be enjoying the best taste of Solapur food and clothing also. So I request all the pediatricians once again to participate in this conference and support the Solapur Academy of Pediatrics and make the conference success. Thank you.
Thank you, sir. Yeah. Solapur is known to hold wonderful conferences. You must be remembering Mahapedicon 2016 conducted at Solapur, where I was the organizing secretary. And last year we have conducted Mahaneyokon 2023, where organizing chairperson was Dr. Atul Kulkarni sir. We all know he is Vice President West Zone, and we all are eager to welcome you for Mahapedicon 2024. Now we will go to a scientific session. Today's topic is protocols in dengue fever, and we have chosen the speaker, Dr. Dhanya Dharmapalan ma'am. Madam, CV of madam. Yeah. Dhanya Dharmapalan madam has done MD and PG diploma in pediatric infectious diseases. She is having FIAP degree and FPIDS degree. Presently, she is joined as a consultant in pediatric infectious diseases, and she is affiliated to Apollo Hospitals, Navi Mumbai. Major achievements are she is national coordinator of Apollo Antimicrobial Stewardship Program for over 70 Apollo hospitals. She is chairperson AMR Working Group International Pediatric Association from 2023 to 2025. She is vice chairperson Global Health Subcommittee PIDS USA from 2020 to 2026. She has edited more than 20 pediatric textbooks, and she is the recipient of several academic awards, and she was invited as a speaker by WHO and various foreign universities. Over to you, ma'am. Just want to convey all attendees, if you have any queries, put your queries in chat box so that we can take all your queries at the end of the session. Over to you, ma'am.
Thank you very much. I'll just 1 second.
Slides are visible, ma'am.
Yeah.
Yes.
Thank you very much. Thank you, Maharashtra IAP, for this wonderful opportunity. I'm really honored to speak today. Thank you, Dr. Amol Pawar and Dr. Kundan. So today before I talk about dengue, I need to acknowledge that most of the content that I shall be talking on is based on WHO resources on dengue. Now, we know that dengue is caused by dengue virus, and there are 4 serotypes, 1, 2, 3, 4, and it belongs to the family of flaviviruses. And family of flaviviruses where you can have Culex mosquitoes spreading Japanese encephalitis. You have Aedes mosquitoes spreading dengue, Zika, yellow fever, whereas even tick-borne encephalitis virus caused by ticks. So dengue is predominantly by Aedes mosquito, and in India, it is mainly the Aedes aegypti. But it has recently also been found that Aedes albopictus is also the vector in many states. So Aedes aegypti, we know, is breeds mostly in the domestic man-made water receptacles, which are found in households like water storage containers, overhead tanks, construction sites, etc. But the other species, Aedes albopictus, is generally prefers natural habitats such as tree holes or coconut shells or in rubber plantations, etc. And as you can see from this graph, that you have the that you have the peak season between July to November every year in India, and it coincides with the monsoon season. So pathogenesis wise, I wouldn't go into details, but dengue is complicated by these issues: antibody dependent enhancement, cytokine storm, vasculopathy, as well as coagulopathy. Now, when we need to first understand how the stages in dengue. It's a dynamic disease, so it has a very short incubation period, maybe just about 3 to 4 days after the mosquito bite and inoculation of the virus. It spreads immediately to the regional lymph nodes and then causes viremia. Now, viremia presents in a patient as high fever, headache, nausea, myalgia, body ache, and rash. Some children might complain of retroorbital pain. And then follows the critical phase after 2 to 3 days of febrile phase. Critical phase at that time it commences, the fever goes down. So the critical phase generally commences around the time of defervescence, and then this is followed by the recovery phase, which commences when the plasma leak resolves, which occurs, plasma leak occurs in the critical phase, and that resolves in the recovery phase. So let's look at this more carefully. So you have temperature, which is high in the febrile period, and then this coincides with the viremia in the blood. Soon after 4-5 days, there is production of IgM, IgG antibodies. Then the fever drops to subnormal temperature, and then again you have a small spike, and this is called as the typical biphasic fever of dengue or saddleback picture. And coinciding with this, in the lab reports, what you find is the WBC drops. It is at the lowest level during the critical phase, and then it starts increasing again. So does the platelet count, which has the lowest in during the critical period, which is around 5 or 6 days of illness. And that is then it takes a few days to recover, and just with the drop of WBC and platelet, you also see in the opposite direction the hematocrit rise. Then what are the potential clinical issues? We find that in febrile phase, it's mostly due to poor oral intake. You might have dehydration, and then gradually with time, the capillary permeability increases. And this is the reason for shock because of the fluid shift that occurs from the vascular compartment. And not only that, there can be organ impairment, DIC, bleeding, and reabsorption. And then later, the fluid is reabsorbed, and during that stage, there's a potential issue of fluid overload. So organ impairment is also another complication that can occur in the critical phase, and that can persist or that can take some time to recover. Now, the problem is, even if we see the transition from the febrile to critical phase generally occurring at day 4 to day 7, it could be still as early as day 3 or as late as day 8. and it generally coincides with the defervescence of fever. So this is very important when you see a febrile patient in your OPD. When you counsel about the fever, first of all, you need to suspect dengue in each febrile child who comes during the dengue season. And when you counsel, you must explain to the parents, even if the fever goes and the child continues to look dull or passing less urine or has other signs like vomiting, please come back. And so, because generally the defervescence of fever is taken as well-being by the parents, so that's important. Secondly, what's very important is to explain them about the warning signs. And also, when in your OPD, you must identify patients who might already be in shock or at risk of developing shock. So these clinical warning signs should be kind of by heart for us. So that is severe abdominal pain, persistent vomiting, mucosal bleed, lethargy, restlessness, hepatomegaly more than 2 centimeters, and any clinical sign of fluid accumulation. So I again repeat, because these are what is extremely important in dengue. The warning signs you need to explain to the parent. Suppose your child has severe abdominal pain, persistent vomiting, any gum bleed, even older children with increased menstrual bleeding or in interval bleeding, that's also very important. Lethargy, restlessness, liver enlargement more than 2 centimeter, and clinical fluid accumulation like say pleural effusion, which might present with breathlessness or a tense abdominal distension. Now, the laboratory warning signs are leukopenia, a rapid decrease in platelet count, and rising hematocrit. So what happens in critical phase is that there is increased vascular permeability, which causes significant plasma leakage, and this leads to deterioration. And please remember, if the child is in leaky phase, it could be fatal if not treated. But fortunately, the plasma leakage duration lasts only for about 24 to 48 hours. And at the same time, not all patients will experience the critical phase. So there are children without significant increase in the vascular permeability, and all you need to do is ensure good hydration. You can ask them to have ORS, coconut water, lemon juice, etc. And generally, the fever subsides with improvement of condition, recovery of appetite, but they may have slight leukopenia or thrombocytopenia. So the other message is, just because it is dengue does not mean the child has to be hospitalized. You need to identify, you need to counsel patients about warning signs and who requires admission. In the recovery phase, the vascular permeability reverts to normal, and there is gradual reabsorption of the extravascular fluid in the next 48 to 72 hours. So what are the clinical clues is the child is recovering is that there is improvement in the general well-being, good hemodynamic status, there could be diuresis, there could be mild fever also, may have bradycardia, and you have the typical classical dengue rash of Isles of Wight in the Sea of Red. The laboratory clues are the hematocrit stabilizes, and please remember hematocrit may be lower, and that could be due to dilutional effect of the reabsorbed fluid. And then you have WBC gradual rise soon after defervescence, and then thrombocytopenia can persist still longer compared to WBC. So if you look at the diagnostic tools we have for dengue, it is right from virus isolation to PCR test to antigen detection test to serology to identify the antibodies, and specificity reduces when we consider the antibodies. But at the same time, what is practical for us, and it's a blessing for us that we have such a beautiful NS1 antigen test, which has such good sensitivity and specificity and we need to do it early in illness, at least in the first 5 days of illness. The antibody production starts after 5 days. IgM antibody also has a good sensitivity and specificity. However, it can circulate in the blood for up to 3 months. IgG can indicate past infection, but IgG positive may not always mean that it is only past infection. If it is clinically correlating, it could mean even secondary dengue. And this is the graph where you can see that in primary infection, it is the IgM antibodies which are higher than the production of IgG, but IgG is much higher in secondary infection. So what are the clinical problems in the different phases? We had alluded to that in previous slide, but I'll just again repeat. In febrile phase, what you can have is probably dehydration. You might have febrile seizures, you might have febrile delirium. But in critical phase, there could be hypovolemia and shock or severe hemorrhage or organ impairment to liver, kidney, and other organs, and recovery. You can have fluid overload if there is inappropriate fluid management. Now, let's come to severe dengue. And severe dengue is defined by one of the three. Either there is severe plasma leakage, or there is severe bleeding, or there is severe organ impairment. So in plasma leakage, the patient has hypovolemic shock and patient has respiratory distress due to fluid accumulation, either pleural effusion or ascites. And in such a situation, also remember severe abdominal pain we saw in the warning signs. It indicates plasma leak, but it can also happen in tense ascites with hepatitis. Then coming to severe bleeding, patient remains in shock despite IV crystalloid and hematocrit is decreasing. So these are problems because of occult bleeding, and it is important to therefore frequently monitor the vital signs as well as the hematocrit. And generally, bleeding occurs in the GI tract and rarely in the brain. We talked about plasma leakage that occurs mostly either in the pleura or in the pleural cavity or in the GI, but bleeding can occur mostly in the GI or rarely in the brain. Now, severe bleeding exacerbates shock. Severe organ impairment is defined as the serum, the liver enzymes more than 1,000 international units per liter, impaired consciousness, or impaired cardiac function. Now, we had a child, 9-year-old, who was referred to as an altered sensorium following an episode of general tonic-clonic convulsions. And this child was admitted outside with fever for 4 days, loose motions, vomiting. Outside report showed dengue NS1. And when this child came, they had successfully resuscitated with fluids, but still you can see that the child continued to have tachycardia. Heart rate was 150, and immediately when he came to the ER, he passed very large volume of Malina on arrival, and this child could not be revived. And when the reports came, we could see that the liver enzymes were very high. When the imaging that was done from the ER had shown encephalitis with hepatitis, and we concluded this was dengue NS1 encephalitis with hepatitis with severe bleeding and shock. So the crucial time, if it is lost, it becomes extremely difficult to revive these patients. So therefore, the best way of management is to do the timely management during the leaky phase. And the clinical examination, though we all know that what we are supposed to look for, but hemodynamic state of the patient is what is extremely crucial. And of course, you would be looking for evidence of the warning signs like mucosal bleeding, like abdominal tenderness, liver enlargement or fluid accumulation. And then there are other signs in dengue that you see like rash. For the purpose of management, dengue has been classified as per the recent classification is dengue without warning signs, with warning signs, and which can progress into severe dengue. And what is we talked already about what we mean by warning signs, but what's important is that we still need to differentiate between clinically who is having severe hemorrhage, who is just having plasma leakage. Also remembering that not all patients go into severe plasma leakage. But there is a criticism about the dengue classification, which changed in 2009 because it removed retroorbital pain as one of the symptoms, thinking that it is non-specific in children. But actually, there is criticism because retroorbital pain, in case the child complains, is a very good marker, it distinguishes from other viral illnesses, because in general, no other viral illness has retroorbital pain as a complaint. And there is difference of opinion about the treatment perspective between countries. Like Sri Lankan perspective is a bit different, so I shall be talking about it. And they have dengue centers where there is zero mortality since many years, and they have a database of 60,000 patients right from neonate to 100 years of age. So what they say is they are a bit more aggressive. They say when you see a patient and you are suspecting dengue, do NS1 as early as possible. And definitely you do a full CBC count on day 3. Because leaking usually starts on day 3, very rarely in the first 2 days. But remember to also do a CBC daily. I mean, I'm talking of the aggressive way that the Sri Lankan guidelines talk about to ensure zero mortality, is that you follow up these patients. But in infants or comorbid conditions, you do full CBC count just at the first point of contact. And if the platelet count drops below 1 lakh, it is a very early indicator that probably the patient is entering the critical phase. And if the platelets are below 1 lakh, or if the child has warning signs, it is better to hospitalize and closely monitor. So this is available on the website, and through their data, they have proven that they do not have any, those centers that do not have any mortality due to dengue so far. And dengue mimics, also we need to remember, is like there could be flu-like illness. H1N1 is very much around, at least in Navi Mumbai. Then you can have viral exanthematous fever, acute abdomen, other infections. So how do you differentiate this? In leptospirosis, of course, you'll have history of wading through flooded water. But in general, you may have more of jaundice, hyperbilirubinemia in leptospirosis, and leukocytosis in leptospirosis, as well as anemia. How do you distinguish between malaria? Malaria, like dengue, also has a very good test, that rapid malarial antigen test, to help out. But in general, malaria, you have more of anemia than in dengue. And in chikungunya, of course, you have small joint involvement than in dengue. Rarely in dengue, you have small joint arthritis. And it is more neutropenia is more predominant in dengue compared to chikungunya. How do you differentiate from an acute abdomen? Surgical acute abdomen is that in dengue, the fever comes first and then the pain. So the child actually may be afebrile when the child complains of severe abdominal pain. Vis-a-vis in surgical acute abdomen, fever may start after onset of pain. And in dengue, there is no guarding. In surgical acute abdomen, definitely you will have guarding. And the pain will improve with fluid resuscitation in severe dengue, but the pain remains even after IV fluids in the case of surgical acute abdomen. How do you differentiate between septic shock is that in dengue, generally the pulse is small or weak pulse volume with narrow pulse pressure and cold extremities. Septic shock, in the initial stage, the pulse may be bounding with widened pulse pressure and warm extremities, but of course later on it may become cold. And generally, the CRP is normal or mildly elevated in dengue shock compared to the septic shock. And septic shock usually has leukocytosis. So in the clinical examination, the important the parameters that one must think about is how is the conscious level, because it indicates the organ perfusion of the brain. How is the peripheral perfusion? How will you look for it is by the CRT, how are the extremities, how are the peripheral pulse volume. You also look at the cardiac output by heart rate, pulse pressure, and blood pressure. And then respiratory rate will tell you whether there's respiratory compensation for tissue hypoxia. And of course, very important is the organ perfusion of the kidney through urine output. So any child of dengue, you need to look at these very important parameters for hemodynamic assessment, because that is what is going to tell you how you should manage that child. So again, I repeat, the conscious level, yes, but more important, CRT, extremities, the peripheral pulse volume, heart rate, pulse pressure, blood pressure, respiratory rate, and urine output. So if you are monitoring these carefully, you'll never go wrong. And the reason I'm showing this slide is in compensated shock, one must remember the conscious level continues to be clear and lucid. So the child will look absolutely conscious, will be talking to you, but yet would be in shock. So how would you identify this is the diastolic pressure rises, so the pulse pressure can reduce. So if the pulse pressure is reducing less than 30, you need to be careful. If there is tachycardia, you need to be careful. This is the time when you can actually, prevent further complications by proper IV management. So again, I repeat, the conscious level, it can mislead you. The child can be completely conscious, but you need to look at the other parameters for peripheral perfusion, the blood pressure and heart rate especially. And you can have quiet tachypnea if you look carefully at the respiratory rate. Postural hypertension is also important. They will complain of giddiness. So that's also another sign of probable need for more IV fluids. Now coming to the main part of the talk about IV fluid management. So again, hematocrit should only be a guide. It is mainly the hemodynamic state that should be the principal driver of fluid therapy. And the reason why I'm saying is, if you look at the concept of hematocrit, if it is persistently rising but the child is unstable hemodynamically, it usually indicates an active plasma leakage, therefore need for further fluid replacement. if the hematocrit is rising, but the child is fine, child is passing urine well, pressures are normal, no tachycardia, then the child does not require extra IV fluid. You just continue to monitor closely. The hematocrit should start to fall within the next 24 hours as the plasma leakage stops. And then if the hematocrit is low and the child is hemodynamically unstable, definitely one must rule out major hemorrhage because the child would need urgent blood transfusion. And if there is decrease in hematocrit, but the child again is stable, then it could be because of hemodilution and reabsorption of extravascular fluids. And then this indicates that you need to reduce the IV fluids in stepwise manner, discontinue immediately to avoid pulmonary edema. So again, I shall talk about this another case that this child, 11-year-old, was referred from another hospital with breathlessness since one day, abdominal pain on and off. But the child had fever 6 days back, had become afebrile last 4 days, and the child presented with tachypnea and abdominal was distended, so had presented with fluid accumulation. But otherwise, the child hemodynamically was absolutely normal, passing urine well. So we didn't do anything. The child just was in the ward, and we just monitored. The hemodynamic status was fine, urine output was fine, no medicine at all, nothing through the IV route, and then child. Sorry, I by mistake muted myself. So this child was basically fluid overload due to plasma leakage and fluid therapy. And we just, as I said, did nothing and the fluid just cleared off on its own. So again, to repeat this in a different form, if there is disease progression and if hematocrit increases, it means plasma leakage. If it decreases, it can mean bleeding or reabsorption. But at the same time, if there is no change, it can also mean both is happening at the same time, both plasma leak as well as bleeding. So again, to say that it is the hemodynamic status that is more important of the patient than the blood report. Treatment related, you may have hematocrit rise due to blood transfusion, or you may have reduction due to IV fluid therapy. And if you look at both disease plus treatment related, you can have a rise when there is plasma leakage and you have given blood transfusion, or decrease when there is bleeding and you have given IV fluids, or no change when you have plasma leak plus IV fluids or bleeding plus blood transfusion. So again, do not be completely be completely dependent on hematocrit. You need to also you need to mainly, not also, but mainly look at the hemodynamic status of the child and then correlate with the hematocrit level. So what type of IV fluids to use? It should be isotonic fluid. It can be normal saline or ringer lactate. And colloids are preferred if you need to restore blood pressure very urgently. And what type of IV fluids not to use are hypotonic solution, that is 0.45%, even during the febrile phase because it has been found to cause fluid overload. Now, why is this very important? It is important because this is how the distribution of fluids are. It is distributed in intracellular compartment. And then if you infuse isotonic fluid, 1 liter of isotonic fluid, then it is 1/4 that goes into the vascular space. But if you infuse hypotonic fluid, it is 1/12 that enters the vascular space. So in dengue, in the critical leaky phase, when there is contracted vascular space, if you infuse isotonic fluid, there is expansion. But if you infuse hypertonic fluid, it is far less that goes into vascular space. So it takes a lot of time for improvement. So that is why it is very important that you use isotonic fluid. IV fluids in critical phase, usually for 24 to 48 hours only, as leaking stops in 48 hours. And how do you calculate is the total fluid in leaking phase is maintenance plus 5% over 48 hours. So that means if maintenance fluid, everyone, we all know to calculate in, say, example, 24 kg, the first 10 kgs, 100 ml per kg, then you have 50 for next 10, you have 20 for the next single digit. So for 24 kg, it comes out to be 1580. So 5% means 50 into the weight, and then you add it up. So this is in 48 hours. So if you, one can argue, oh, this is even less than maintenance for 2 days. But actually, this is the total volume that is recommended so that you do not give too much or overload or cause pulmonary edema. So in the leaking phase, especially if the patient is not in shock, and this is what each one of us has to remember, that once you know that the patient, the fever has gone, patient is in the leaky phase, you have warning signs, or you have evidence for that, you have high suspicion, you start calculating this, you know what volume you need to infuse totally in 48 hours. But how will you infuse is, if the patient is in shock, it is 10 to 20 ml per kg over 1 hour. If the child is in hypotensive shock, a larger volume in a quicker time, that is 20 ml per kg over 15 to 20 minutes. And you need to basically target for good perfusion and urine output of 0.5 to 1 ml per kg per hour. And this calculation should always be based on ideal body weight if the child is overweight. And every bolus you have to reassess. So dengue is one illness where you just can't just start IV fluids and see after 12 hours in the evening, you start IV fluids in the morning. No, this in leaky phase, especially, you need constant monitoring of the hemodynamic responses. And after shock correction, you reduce the IV infusion rate in such a way that you can give the total fluids in 48 hours. So you reduce the rate as the child passes urine and as per the hemodynamic condition. And towards the critical phase, actually, the rate of plasma leakage reduces, and therefore you would require less and less fluid. But if the patient has come pulseless or is hypotensive, you might even need to access through the intraosseous route, and it is preferable to use colloid if available. Otherwise, you might have to resuscitate with crystalloid at 20 ml per kg over 15 to 30 minutes. The reason why colloids are preferred is because it helps to urgently restore the blood pressure, especially those with pulse pressure less than 10. And then you continue the crystalloids and monitor the child. Aim for at least 0.5 to 1 ml per kg per hour. And again, after 48 hours, you stop the IV fluids. So this is what is the management. And this is what is also in our national guidelines. So you can go through these national guidelines for clinical management of dengue. These are our government guidelines 2023, where it clearly mentions whatever I explained, that the fluid, though here the allowance is oral plus IV together, for children, it's not very easy, especially smaller children, but you should not exceed M plus maintenance plus 5% in 24 hours in non-shock patients. Now, the difference in the Indian and Sri Lankan guideline is Sri Lankan guidelines will say even in shock, do not exceed more than maintenance plus 5%. WHO guidelines also similarly talk about you start if the patient is in compensated shock, you start at 10 to 20 ml per kg per hour. But you see this is very important. You gradually reduce after 2 hours, you reduce further, then you reduce to 7 to 5 to 3 if the baby is passing urine well. And then you see this stop IV fluids at 48 hours. So whether it is Indian guideline, whether it is WHO guideline, whether it is Sri Lankan guideline, all guidelines, even in a shock patient, asks to stop IV fluids at 48 hours if there is improvement. Now, if there is no improvement, you need to look at the hematocrit, and then you can give the second bolus. If there is improvement, again you follow the same step of gradually reducing the IV rate. But if the hematocrit has fallen, you might need an urgent blood transfusion, or you may you might even have to use colloids. Evaluate to consider blood transfusion if there's no clinical improvement with colloids. So colloids indication would be if there is hypotensive shock or narrow blood pressure. Now, knowing when to stop IV fluids is critical. So I showed you 3 guidelines. All 3 guidelines, even in a compensated state shock situation, asks to stop IV fluids at 48 hours of the leaky phase. And this is so that the extravasate fluids now can be reabsorbed, but definitely you stop if the child has breathing difficulties, pulmonary edema, hypertension with good volume pulse, and definitely 48 hours after effervescence. Colloid therapy, I already did talk about that its role is mainly in the hypotensive shock, or you have given 20 to 30 ml per kg crystalloids, but there's no improvement, or the hematocrit does not decrease after the administration of colloids. You limit to 30 to 50 ml per kg. The advantage of colloids is that it stays longer in circulation and causes faster reduction in hematocrit, but it comes with side effects like allergic reaction or impaired coagulation or potential renal impairment. So summary of IV fluid in dengue is the problem is that if you give inadequate fluids, it can lead to hypovolemia and hypotensive shock. Excessive fluid can cause pulmonary edema, respiratory distress, and clinical deterioration because worsening pleural effusion and ascites. And it is you need to be not too less, not too much, and that would help you to attain what we want in dengue: a normal CRT, heart rate, blood pressure, pulse pressure, urine output of at least 0.5 ml per kg. And so now the next question is that what is the indication of platelet transfusion? So the indication is you transfuse platelets only if active bleeding is present. There is no role of prophylactic platelet transfusion unless the counts have reduced to less than 10,000 without bleed and those who may need emergency surgery. So otherwise, if the platelet is 20, 30, 15, and the child is not in active bleeding, do not transfuse platelets. Now, during COVID pandemic, when we had these cases of MIC and severe dengue, since ferritin levels are high in both, there was a bit of problem about how do you distinguish MIS-C? And this is one of the papers where they suggested that in multisystem inflammatory syndrome due to COVID, you have oral mucosal findings, raised inflammatory parameters, but more of coronary artery abnormalities. So that can help in distinguishing from dengue fever. Now, we had a child, a 13-year child, who was referred with a report of RMA positive for hospitalization. The brother also had fever, and NS1 was negative outside. And the child was not sick looking because RMA was positive. We started on, for falciparum, we started on artemether lumefantrine. And but though it didn't, CBC did not really correlate. I mean, hemoglobin was fine. The smear did not show malarial parasite, but we had started on artemether lumefantrine, and then there was this slight dip taking place in total count and platelet count, and fever persisted. So we realized that there's something wrong happening, and it was increasing in intensity and frequency because both the CBC did not show any malarial parasite, and started wondering about this report. And the fever further increased, the platelets started falling, and so did the WBC count. And then suddenly she developed the classical dengue rash on, and then at that time fever was still very high. Uh, so the urine was being monitored, so urine was fine, but then again there was dropped in 2 cell lines. And then we wondered, did we really have a dual infection because both are bitten by different, I mean, caused by different species of mosquitoes. But we also realized that, a rapid malarial antigen test can be falsely positive to the child, or it can remain positive after treatment, but the child had no history of being detected with malaria before coming here. But so it kind of looked like maybe it was false positive RMA, which we treated. And here on the 6th day, dengue IgM was positive. But because of the fever, drop in cell line, and the child started looking sick, we did the ferritin, which was 28,000, and then bone marrow biopsy showed that it was dengue with HLH, and this patient had to be pulsed with methyl prednisolone. Regarding congenital dengue, we had a newborn. The mother had dengue. This baby developed fever on 2nd day of birth, and NS1 was positive. And this baby had fever till then, 10th day, did not have any major complication. But I just wanted to, the reason I presented is because congenital dengue is must be considered in a neonate who has fever and rash and born to mother who is ill with dengue within 10 days of delivery. So one must think about this, should not miss it, because what happens is the baby might be discharged on day 2, day 3, but baby can become symptomatic after discharge. So from anywhere between 4 to 11 days. So that's very, very important. And they may just present in shock, which might look like septic shock. So on suspicion, if you have a suspicion that mother had dengue, or whether mother had dengue, do antigen and serology both in mother and baby, but do not miss congenital dengue, though it is little rare. And on discharge, it's important to educate about vector control measures to every patient of dengue, talk about repellent creams, about using mosquito net, and about not having open tanks, or having flower pots which have water retention, etc. So to summarize, dengue has a wide variety of clinical presentation. It is very dynamic, and one must have a low threshold of suspicion for dengue, especially during this season. And majority, fortunately, are self-limiting, but you have to still catch that small subset who can have severe plasma leakage with or without bleeding. So therefore, in such children, warning signs help, and identification of the beginning and end of leakage is most critical. And it is always the clinical examination, the hemodynamic status, which is the main tool for IV management with guidance from hematocrit. And of course, you need to treat concealed bleeding and other complications if you want zero mortality in dengue. Thank you.
Thank you, ma'am. You have covered all aspects of dengue in detail. Also, the approach was case-based, so it was easier for pediatrician to correlate the cases. And the whole concept of protocols in PSU is that we compare various protocols and we give various protocols in detail, as you have covered Sri Lankan guidelines, national guidelines, everything, and then give practical guidelines to our common pediatricians who is working at the periphery. So the message was clear cut. There are some questions in the chat box that I ask you. One question is very important and practical. What is the role of carica papaya leaflets, leaf extracts in dengue-induced thrombocytopenia?
Okay, so I mean, I will tell my personal way of handling this. I tell them that it is the fluids that are important, but if you believe you can have it, I have no problem. But it does not mean that if the child doesn't like it, do not force it and do not divert your attention to again from IV or oral fluids and monitoring urine output. So I tell them that I tell them, that's not important for me. What is important is if the child should pass urine well, platelets will come up on its own. After explaining, I also tell them if you believe if you want to, you can have, but this is what I need.
Yeah. Every patient is
Platelets will
leaf extract there is there.
Because even if you say don't have, then they feel that, they then go out of the way to get papaya leaves. So I give them the freedom that if you want, you take, but I want this, that the baby should have, because in that attempt, they might lose focus on giving adequate fluids. And I also tell them platelets which drop will come up. It's always better to show the graph, okay, in the start itself, when you admit a dengue patient, say you have admitted on day 3, let them know platelets are going to drop next 2-3 days, and then it will gradually rise. Because while you're monitoring CBC, the next day, oh, platelet kam ho gaya, they start getting anxious. So in the start itself, you explain this is what is the expected course, this is what is going to happen, and we need to monitor urine output. And as platelets start rising, it's recovery phase, then you're not worried.
Yeah. Good evening, Nitin Shah, sir. He want to.
Right. No, I wanted two things. The number one, that if there is something which is not useful, just because it's not harmful, we cannot allow them to take. So that's number one. I would strongly discourage them from taking any medicine which is not required. Number two is about the platelet count out that we are there, and that's the subject. There are two things I want to say. Now, when you do a CBC on day 3, day 4, platelets are dropping, you always do an immature platelet fraction. IPF. What is retic to an RBC is IPF to platelets. If the IPF is high, you be rest assured in next 24 or 48 hours, the platelet will start rising. But that tells you that the young platelets are being formed. Because you can have low platelet because of either marrow suppression, okay, in which case the IPF is low, or a recovering marrow where the marrow is going to, so IPF is high and the marrow is going to bounce very soon. So that's number two. And the last thing, there are some dengue patients who are okay, the fever has gone, shock has gone, with or without admission, whatever, but the platelets continue to remain low for 10 days, 15 days. That means now they are post-dengue ITP. And again, their IPF will be helpful. IPF is persistently high. That means now is like you have a URI following which after 1 week you can develop an ITP. There is no reason why a dengue virus cannot precipitate ITP. And they are treated exactly on the same line as ITP. If there is no bleeding, observe. If there is bleeding, give them steroid. I prefer to give steroid for the first time for two reasons. One, the patient is staying away, then he may not come back in time if there's bleeding. Number two, it reassures parents that there is some drug which increases platelet in an ITP. So in general, also in ITP, the first time I tend to use short course steroid, 4 days, 8 days. The platelet become 50 lakh, 50,000, 1 lakh. They know, the doctor knows what medicine to give if the platelet drops and if there's bleeding. So that way it works both ways. And last comment on the HLH, many of the dengue fever continues, they are not very sick. So they may have some compound HLH. We don't need to do marrow in such cases. You can do fasting triglyceride and ferritin. If they're sky high, just short course of oral steroid, few days and everything disappears. But if they are sick and hospitalized, like Dr. Danya very rightly said, then you need to treat them. But remember, dengue HLH is not same as any other HLH. They hardly have any CNS involvement. So normally we in HLH prefer dexamethasone because it crosses the blood-brain barrier. That's a typical primary HLH. But in the secondary HLH, you can do away by just using prednisolone instead of using Dexa, because Dexa will be toxic. It can lead to sepsis in a child who just had dengue with low count and recovering. You don't want to precipitate another problem of sepsis on the hand.
Thank
Anyway,
you.
excellent talk, Danya. I mean, as usual.
Thank you
Thank
very
you,
much, sir,
sir.
for your pearls of wisdom. Thanks.
Thanks for input, sir. Ma'am, there was one question from Dr. Narayan Nagmode. How to manage abdominal pain in dengue?
It's to increase the IV fluids. Again, you just monitor urine output and increase IV fluids. No medicine specifically.
And there is one question from Dr. Arnav Chavan. What are the indication of ECG in dengue bradycardia?
If you are finding irregular heart rate, you might want to consider doing an ECG. I mean, I don't know if there's anything else anyone wants to add, but or if the
There-
patient is very critical, myocarditis you are suspecting, that's also another.
There is one question from Dr. Shweta Shinde. How frequently in children do we get a second peak of fever after leaky phase of has subsided?
You can get, that's not very uncommon. You can get the second phase of fever, but the second phase is generally milder than the first phase. Generally, it's not very intense usually, but you can have, yeah.
There is one question. What is the role of doxy in dengue fever?
There's no role for dengue specifically unless you feel there is rickettsia co-infection, but that's very rare that you have rickettsia also and a dengue.
Yeah, a role of 3% NS in CNS involvement.
3% NS in CNS involvement, that would be probably in case of encephalitis, though I'm not an intensivist, but dengue encephalitis has its own management. So I think in that.
What the two questions are related. Does dengue fever has cardiac manifestation? And second is bradycardia is a sign of myocarditis in dengue?
Bradycardia is not a sign of myocarditis. Myocarditis, if you have, if the heart rate is not loud on examination, I mean normal, if you're you feel it is distant, muffled, and then you have low voltage in the ECG, or you can collaborate with the creatine kinase, but I don't think it is a sign. Bradycardia can occur normally also.
Yeah, one practical question is there from Dr. Gajanan Dharmure that itching is seen in dengue. Does it is having good prognosis?
Yeah, there are studies which have shown that appearance of rash and itching is indicative of a recovery phase, though it is like mixed in literature. There are experts who do not believe. I mean, but in a study which I also conducted, we did find that itchy is a good sign.
Practically, we see always there is itching, and after 1 to 2 days, platelet is increased.
Yeah, it's a good sign.
Yeah. And one question is, I think you have covered this. Anti-malarial, when to use dengue? If not sure of dengue only, when to suspect dual infection? That thing we have covered in one slide, I think.
Yeah, dual is very rare, and you have good tests.
Yeah, there is one question. I think Nitin Shah sir has already answered. Does a short course of steroids if you are suspecting HLS in dengue?
Dr. Nitin Shah, sir
Yeah.
wants to comment. He has raised his hand, I think.
Sir, dose of short course of steroids if suspecting HLH.
Sir, please unmute. Sir, please
Yeah,
unmute.
okay.
Nitin Shah, sir?
So I already said
Yes,
that
sir.
if you have a less sick patient, probably on OPD base also, or about to be discharged, the fever is the bothersome symptom. Everything else is okay. Just do fasting triglycerides and ferritin. If they're high, you can discharge even the patient on steroid and repeat a CBC after 2-3 days. I just want to comment on that ECG thing. I think the person who asked probably has seen that there's a study from East India, which is reported in Asian Journal of Tropical Pediatric, which says that in dengue around 10 to 12% have silent myocarditis. We, of course, if you don't investigate, they recover. We don't even know. But bradycardia is seen in most of them. So that's why, unlike in a myocarditis, where you have tachycardia out of proportion, this is one where there's bradycardia. I mean, they don't know what the reason is.
Yes, sir. Very few child goes to dengue encephalitis. it has bad prognosis. Can we prevent it?
Actually, if it is neurotropic, I mean, if it has directly hit the brain, it would be unfortunate. But when we listen, I mean, I don't know how many of you had come to Daman, where there was this Sri Lankan expert on dengue who spoke on dengue and talked about zero mortality in their center, where they said that every dengue mortality is preventable. Though it's interesting, we should ask him about NS1. I mean, encephalitis. If it
Dr. Vijay Vele sir is there. Sir has raised the hand. Sir,
Yeah, a few comments. Good presentation, Danya. I've been listening to you. And one is somebody asked about biphasic fever. I mean, what she probably means is biphasic fever is not very common in pediatrics. I mean, it's very difficult to. So the dictum is if you have an acute febrile illness in dengue is endemic everywhere, especially during monsoon season, immediate post when dengue cases start coming. You treat every dengue fever as secondary dengue. If it is primary dengue, the patient will not leak. If it is secondary dengue, patient will leak. And out of those who leak, only 5 to 6% develop severe illness. Rest of them recover on their own. I mean, the leaky phase may last for 12 to 24 hours without any clinically evident, signs of leakage. That is one. Secondly, myocarditis. I mean, the experts differ on this, and the Thailand people say that there is nothing called myocarditis in dengue. I mean, everything is related to the dengue hemodynamics. Once you stabilize it, everything recovers. Unlike any other myocarditis, it does not lead to increase in enzymes or the exact reason is not known. But by and large, it is helping. Though I remember distinctly, there was a year when a lot of patients presented myocarditis, and especially from Vadia Hospital. I remember Dr. Parmanand talking about it a few years ago. That is second. Third is less is better. That everybody should remember. And Danya has very correctly said that you monitor the peripheral pulse and urine output. So it is better to give fluid on the lower side, monitoring the urine output. And you aim at 0.5 to 1 ml per kg per hour of urine output. And as she said it very correctly, 99% of the time, the leakage does not last beyond 48 hours. HLH, one important comment that I want to make is we are, especially post-COVID, everybody is in the habit of asking for ferritin. Ferritin is an acute phase reactant and it can increase in infection, any infection. And it can go in thousands also in dengue. So one should not blindly ask for HLH unless you have clinical suspicion of dengue. So dengue, which is the patient of dengue who is expected to recover, continues to spike or liver enzymes start rising, then only should you ask for ferritin. Otherwise, it misleads you and you end up over-treating HLH. It has HLH. And there can be mild, as Nitin said, mild HLH, which is self-limiting, which does not require any treatment. So I thought these are a few things that you must remember.
Yeah, thanks for input, sir. Dr. Minat also want to share his thoughts.
Good evening, sir. As usual, extremely good presentation.
Louder.
Am I audible?
Sir, voice is little low. Yes, sir. Now audible. Sir, you can.
I think we
So,
lost it.
Good evening, sir. As usual, it has been excellent presentation. I have two things too. Number one is with regard to bradycardia, as long as hemodynamics are stable and you have a heart of up to 45-40, you can wait and watch. Up to 45, as long as hemodynamics is stable. That's number one. Number two, I want to ask about, as Devle sir has can we see how we can anticipate secondary dengue?
Sir, can you switch off your video? Your voice is breaking. I think rate issue there.
Okay.
You switch off the video, sir. It will be clear.
I think we have lost him. He will join again probably.
Ram Gopal sir has joined, sir.
So, Dr. Kundan, I just wanted to ask, I mean, either Danya or whosoever, or just inform that, dengue is now a vaccine preventable disease.
Yes,
So we have spoken about management. It's a dreaded disease. You don't know who will go into what problem. But now we have not one, but two excellent vaccines. One from the Japanese company, Takeda, which is Qdenga, it's likely to come in India shortly with an efficacy of almost 85 to 90% against hospitalization and dengue shock syndrome. And no increase in the hospitalization, unlike what you saw with the Sanofi vaccine. This vaccine has been now having 4.5-year follow-up, 2 doses, 0 and 3 months, and can be started from 4 years of age onwards. And even a better vaccine, probably, is a single-dose vaccine from Butantan, Brazil. Now, that strain is actually an NIH strain, US strain. The NIH has given now to Indian manufacturers. So Panacea and Serum both are working on that single-dose vaccine. That can be given as early as 2 to 3 years of age, one dose, and the efficacy is almost same as that of 2 doses of Qdenga. So very exciting vaccines are coming in the near future. And hopefully, I mean, of course, as Dhanya said, Dr. Lakkumar from Sri Lanka says he has zero mortality. He almost means almost 0%, because there will be some cases of fatal hepatitis or fatal encephalitis which you cannot prevent, but they are rare. But generally, with good fluid management, you will be able to save a lot of people. But you may actually prevent altogether dengue vaccines. Another reason why pediatrician will go out of practice.
Thank you, sir. Thank you. When will it hit the market, sir? Most
So
probably.
dengue, see, the Takeda has a problem of supply because there is so much of demand of the vaccine. Is already licensed in more than 6-8 countries, part of the national program in 2 or 3 of them. Some are giving from 6 years of age onwards, some are giving from 12 years of age onwards, some are giving only in adults, etc. There's a limited capacity. So what I understand is they have around a lakh of doses which are probably available for India. But as I understand, there is a pressure on the Takeda to fast track the dengue vaccine in India. If it is fast track, which means government is going to help them, and if government helps them to fast track, probably they will take away all the doses. Like what happened with the Sarvavec of Serum, they made 2 doses for the public health. They said no, you can't market it because we need it. Fortunately, otherwise the entire HP vaccination in public health was delayed. So those 2 doses came in market, and now they are 1 dose. So dengue probably, if suppose this monsoon, we haven't had very bad dengues for last 3, 4 or 5 years, maybe I would say in Bombay at least. So if that, suppose now it's a chance for the next outbreak, and if a huge outbreak happens, they will be sucking up the vaccines in the public health. So we may not get it in the public health, but I understand it's expensive vaccine. It almost costs 10,000 rupees.
Thank you, sir. Thank you for input. Minaj sir is there. Sir,
Yeah. My apology for that inconvenience. Dr. Dhanya, I wanted to ask one question with regard to what Devle sir has already said. I mean, how to anticipate the secondary dengue?
Through the warning signs, and that is why I put that slide that anyways leaking doesn't occur in first or second day of illness. It's usually from the 3rd day onwards that leaking takes place. So you need to counsel every parent about warning signs. And if you feel there would be problem with compliance, you might go for CPC every day from day 3 and see.
To Minaz, I would like to add only one thing. That
Sir.
every dengue you treat it as secondary.
I
This
agree.
NS1 will only tell you that it's dengue. It does
I
not
totally agree
differentiate
with you.
primary from secondary. So
Yes.
unless proved otherwise, I mean, you continue to monitor. If the hematological or clinical signs start suggesting leakage, you call it secondary dengue.
Yeah.
And then another aberration that we have seen last year is dengue deteriorating on day 2 and day 3, which is little unusual. So
Yes,
last year
sir.
we had a good number of cases. And then there was a year when we saw a lot of CNS dengue, encephalitis. They can have necrotizing encephalitis and brainstem encephalitis. So,
Dr. Bhavesh sir, scientific convener, want to talk something. Sir,
So 2 questions to the experts, all the experts. So one is congenital dengue. So when the child is born to a mother who develops a dengue fever and confirm on day 2 or day 3 after the delivery, and baby is asymptomatic, how to monitor laboratory wise apart from the clinical. I think we discussed about the clinical monitoring, but how to monitor the laboratory wise, because this baby is really going to the dengue shock at any point of time. And second is that do we have a different clinical manifestation of a different serotypes of dengue? And do we have any prevalence of various serotypes in our area, like Mumbai, Navi Mumbai area? Do we have any data on this prevalence of the different types of dengue?
So it is type 2 that is more prevalent in India, we know, and 3 and 4 have also been reported, but I do not know Mumbai specific what is the serotype. I don't know whether there has been such a study, but maybe if somebody knows, can put it in the chat box if they know. The second is
There is a paper, Janya, by Dr. Jagtap's group in the PLOS in 2023 that looks at the DEN 1, DEN 2, DEN 3, DEN 4. The color charts are available. It doesn't give exact number, but tells you the trend. And in general, it divides into north, east, west, central, and south as 4. And they, as you very right said, most of it is orange, which is DEN 2. But the DEN 4 is definitely coming up in south and in the western and central. And unfortunately, we don't have efficacy of Qdenga against type 4 till shown in any study, because there were very few cases when the primary study was done. And for the one dose Butantan vaccine for both type 3 and type 4, we don't have efficacy because, again, when the study was done, there were hardly any cases of type 3 and type 4. But he very rightly said type 2 is the commonest. And in North India, somehow type 3 was there initially in 2006-7 when I was the president, and of late it is a mix of all the 4 types, including even some cases of type 4. So there is that paper from Jagtap's group in the PLOS pathogens.
Does it have a different clinical manifestation, or it's kind of the same everywhere?
So type 2 is the most severe form. That's what they say always.
Our President Ram Gopal sir is there. It was sir's idea to take monsoon. He said, "Are Kundan, monsoon is
And the
up."
second question's answer, congenital dengue monitoring.
Yeah. So this congenital dengue needs to be suspected if the mother has before delivery within 10 days, but also it has been reported that mother has been diagnosed post-delivery. So in such a situation, how would you monitor? Now the leaking can happen even on day 11. So does not mean that you keep the baby for 11 days, but the same refusal to feed, if there is any fever, if passing less urine, very close monitoring, maybe daily follow-up. And
That's
if you
a clinical monitoring that I think every pediatrician would do. I'm talking about the laboratory monitoring. Do we really need to work up for these babies?
You mean from day 1? Yes, actually.
To prove any vertical transmission. To prove any vertical transmission.
I mean, I would say if you have a patient who has been diagnosed, a mother, even if you do a CBC daily in that neonate, because I mean, if you want to look for a laboratory monitoring, a CBC is what I look at.
No, a serology versus a PCR. What I would tend to understand that.
NS1, IgG, IgM, all 3 you can do, because.
And what point of time?
At what point of time? So what we have seen is generally they present with fever. So first, I mean, if they present with symptoms that day, or if you're suspecting, you can do, you can just check the antibodies in the mother, NS1, IgM, and look at, I mean, that's a tricky question actually.
And the reason of that, we had one baby born to a mother who was fine otherwise at birth. And on day 2, mother developed the high fever and chills and rashes. Day 3, mother got diagnosed. Of course, baby remained normal. And mother got diagnosed to have a dengue. And we also then did the PCR for a baby. And that turned out to be a positive. Fortunately, baby remained well throughout the 2 weeks. And we kept monitoring on outpatient basis. Baby remained absolutely fine. But the point is, at what point of time should we send the PCR? At what point of time should we think about sending the NS1? At what point of time we should think about sending the IgM? So that's a question. And second, in a most clinical scenario, other than the congenital dengue, many of the parent only ask for a dengue NS1 in the first 24 hours of the illness itself. And it turned out to be negative. So what is an ideal time to send the NS1 antigen for all practical purpose?
Ideal time is after 24 hours, as per the experts in dengue.
So just to respond to your question, Bhavesh, about the congenital dengue or whatever you call it, first few months dengue. So, I mean, why are we interested even knowing whether he's PCR positive or no? You're going to hit him when the first symptom develops. I mean, no baby who is born to dengue positive mother with an antibody already there, now going to behave like secondary dengue so straight away, is going to be on day 1 in shock. I mean, that would never happen. So moment the child develops fever, you know he's a dengue exposed baby, you would investigate very thoroughly and go by clinical monitoring and the basic laboratory monitoring. Whether PCR is positive, negative, like in your patient PCR positive, it did not matter because though he was PCR positive, he was asymptomatic. So I think instead of doing that, probably you will have a very high threshold of investigating CBC on day one in a baby born to mother who is dengue positive.
Yeah, Vijay sir
So,
and
yeah,
Vinod sir.
so congenital dengue, yeah, I mean, we should call it perinatal dengue, number one. Number two,
मुंह दिखाई करो भाई.
no. So I've just come back. So congenital dengue, it is better to call it perinatal dengue, number one. Number two, the dengue, or perinatal or congenital dengue, who become bad, actually they have, sensitization because of maternal dengue. And the first direct contact with dengue virus, it leads to, secondary dengue kind of a phenomena, cytokine storm in them. Congenital dengue, unlike your pediatric dengue, does not have those typical features of leukocytopenia. I mean, they have many times leukocytosis. They can have the levels of liver enzymes can be normal for some time, and if elevated, can take longer to come back to normal. They have hyponatremia or hypernatremia. Both are known. So congenital dengue is so the best way is you continue to as Nitin said, clinically monitor. It does not really make any sense if suppose you have diagnosed dengue in a mother to just go on doing PCR or some NS1 test in a baby who is otherwise asymptomatic. Best is to monitor them and at the right time you do. So management wise, you need little longer follow up and do the test as and when required.
Vinod sir.
Yeah, I had the same feeling because why the PCR was done if the child is asymptomatic. If the PCR would have been because these tests always put on the on the cross road to us. If the child is symptomatic, yes, and I think I agree with what Yevles sir has said. Will look more clinically than lab wise in such patients. That was the same thought process I was thinking of.
Yes.
But interesting case, Bhavesh bhai. Interesting case.
Our president sir is there. Ram Gopal sir.
Good evening, everyone. Sorry for joining late, sir.
Jai Shri Ram.
Good evening, sir. Jai Shri Ram, sir. I am at Kolhapur for Capcom. I hope you all are enjoying the session.
Yes, sir.
Even this Wednesday Wisdom, we are covering all the majority monsoon illnesses.
Yes, sir.
Good.
Thank you, sir.
Great academy, great chairperson, great speakers, great topic, great moderators.
Nitin sir, I had always one question with regard to fluid therapy in dengue. Is it okay I ask about that?
Yeah, ask Dr. Dhanya. I mean, I'm not
Dhanya,
a specialist.
Dhanya, what is that 5
You
ml,
answer,
3
sir.
ml?
Vinod sir, you only answer it.
No, I have all, see 5 ml, 3 ml right from the beginning. What is the take? What is the practice actually?
It is just bringing down the rate. There's no.
No, but then, if you say 5 ml per kg, and then most of us don't monitor hourly, right? And then we end up giving extra fluid.
Correct.
So, what is the take of this 5 ml, 3 ml, or 5 ml, 7 ml, all those things? I think we should come down in that.
I think, Minaz, what I mean, we do in Hinduja is, of course, I'm not an intensivist, neither I'm a great infectious disease specialist. But what we do is, a patient is not in shock, start with maintenance fluid.
Yes.
You go by your hematocrit previous day if it's available and what you have now. Repeat after 6 hours, your fluids have to go up or down.
Yes.
That would completely prevent anything happening. So first, in a hospitalized patient who do CBC 6 or 8 hourly is not an issue at all.
So what usually we do, sir, we start maximally 3 ml per hour.
That's would come to maintenance. You calculate 10 kilo child.
That's all.
To maintenance.
And then and maintain, see the urine output.
Absolutely.
Urine output is very good marker.
So,
yeah, but that too don't aim at a very high urine output. Aim at
0.5 to 0.8 ml per kg per hour.
Minas, in fact, if the baby is passing urine, you need not even start IV fluid. Second,
Exactly.
IV line, just maintain the IV fluid. I totally agree with you that 5 ml and 4 ml business, that leads to more fluid overload.
Exactly.
Most of the pediatricians get away because most of the cases are primary dengue. And
so what is happening, sir?
And not everybody leaks very profusely.
True.
In that the pediatric kidneys are very strong. They can tolerate little more fluid. But you do it in an adult. I mean, they laugh at us. If you have a 25-kilo child, you start 10 cc per kg per hour as we used to do in past. They see you are giving more than double than what I'm giving to an 100-kilo
Exactly.
adult.
So I feel, we should not, but at least, as I rightly said in the beginning by all, less is more and more monitoring.
Yeah, madam has given already that when to stop fluid is very important.
Yes.
Second, most important is that always use isotonic fluids. Most of the time they use hypotonic 0.45 isolate P. So the message is clear cut that you should use, whenever you are using fluid, use isotonic fluids. There are many questions. One word answer. Role of essential amino acid like glycine during therapy as adjuvant.
No idea. Sorry.
Role of artesunate.
No.
Not at all.
There are many questions, so I'm just taking straight.
So they're interesting question. Take all questions.
Vitamin K is something that needs to be discussed actually. Vitamin K, when there is liver coagulopathy, that's fine. But I don't know if other experts would want to say about vitamin K in dengue.
Yeah.
So most of the experts say that if you correct the hemodynamics,
yes,
not required.
The one question is how the earliest dengue NS1 test should be asked. It may turn out to be negative if done before 24 hours. Then second, in first 24 hours, dengue NS1 or dengue PCR for diagnosis.
PCR is very costly.
Yeah. And one important question is cholecystitis, radiological, we get USG. What is the significance?
It's not cystitis, it's gallbladder wall edema. That also is a sign of leaking phase. It's a good sign.
But that is the earliest sign.
They say that earliest is platelet fall.
Platelet fall.
Radiologically, it is gallbladder wall edema for dengue.
Yes. Dengue will be always an interesting topic and there will be questions. So we have to stop somewhere. So I think most of the questions have been taken for. I will ask my.
Can I make one comment?
Yes, sir.
Since you're talking about many nursing homes in the periphery, they have a sonography machine with them.
Yes, sir.
So especially those who have ICU, and many of them are tuned to looking at IVC, this thing filling. So this Lakkumar Fernando, what they have a 16, 18 bedded wards, and each bed has a multipara monitor, and there is a centrifuge, and there is a triple card test, and a sonography machine. And everyone in the unit, right from the nurses to RMOs, everybody is trained to put the probe, sonography probe in the lateral decubitus position on the chest. And leak is the earliest sign that they pick up. That marks the beginning of leak. And then you have 48 hours from that time. So, 48 hours ka khel hai saga. So that's because we know we have very strict TCP NDT guidelines, so everybody cannot have but those who have sonography machine in the peripheral, they must develop this kind of habit so that, and overall, as we have not seen severe dengue because everybody has become wise. The patients, the doctors, patients come early, doctors recognize early, doctors have, including me, we have become wise over a period of time. Like 20 cc per kg per hour to no fluid at all in a child who's passing urine. So most of the mortality in the past occurred because of fluid overload. So that has gone down. Thank you.
Sir, sir, what is that sign you're talking about, the that sonography?
You make the patient lie in lateral decubitus position. If you have sonography, you can do it in any position. And fluid in the pleural space. That's an early indicator of heralds the beginning of leaky phase.
Understood. Got it, sir.
Thank you. Thank you for all inputs. I would like to thank Madam wonderful session and covering the topic in detail.
Very good.
Dr. Ram Gopal sir for taking initiative and suggesting this topic before the monsoon to sensitize our pediatricians for managing the cases effectively. Then Secretary General Amol, Scientific Convener Bhavesh sir, the entire OB, EB, and especially joining and taking interesting conversation forwards, giving inputs about vaccine, Dr. Nitin Shah sir, Dr. Vijay Evle sir, Dr. Minaj sir, my co-EB Mateen, and all the people who have joined for this wonderful session. Thank you all. And we are already running ahead of the time. 10:30 has already passed, and almost 300 are still joined to the this Zoom meeting. That shows the success of this session. Thank you all.
कुंदन, every time if you say 300, मेरा एक पार्टी बढ़ जाता है नितिन शाह सर को.
सर आपकी बार 400 था, 350 तक गया है.
Because sir ने बोला है every time if there is more than 300, I have to give him one party.
सर अभी 300 बार बोला है, 400 बार नहीं बोल सकते, डेंजरस है वो.
नहीं सर 300 ही बोला मैंने.
400 तो 280 तक जाएंगे हम.
नहीं राम, आई एम मेकिंग ए ऑफर. अगर 12 के 12 महीने 300 के पार हो गए तो मैं तुमको पार्टी दूंगा. चलो
चलो सर. That is, I think all credit goes to the team Maha AP. Everyone is working hard.
Perfect.
Kundan,